Okay, you want to keep them between 90 and 92. Normal brain patient, or normal patient or brain issue in a non-lunger, between 92 and 94%. So the idea of 100% oximetry all the time, not anymore. I don't have any capnography numbers to give you, but I would suggest that your capnography also in a normal patient would be between, same numbers probably here, okay? So we're not after 100% SATs on these people anymore. That's over and done with. You're also going to see changes I don't know when this is coming. It'll just all of a sudden appear. In your hypothermia protocols for temperature, where to maintain their body temperature, that's also changing because they found that the numbers they were using and the temperatures they were shooting for were too low. They were making the patients worse. So, yes, I'm talking about induced hypothermia. So that's going to change as well, and you're going to see that sometime in the next 6 months pop up in the protocols. Have you seen anything yet, Greg? I don't think the protocol committees.
They started talking about it down in Collier County.
Okay, yeah, you're going to see that happen. So we know the brain's sensitive to oxygen. That's why these have been modified. Too much oxygen causes vasoconstriction, which therefore impacts the circulation of the brain. You don't want that. Shuts down the functions of the brain. And glucose metabolism. What does glucose do to the brain? Fuels it. What does it do to the permeability? What happens? In a patient who has a high blood sugar, what happens in their brain? Same thing happens in your eye in a patient whose sugars are high. The lens in your eye, when it gets too much sugar in it, which it does, it's called sorbitol, absorbs water and swells, and that's why diabetics who are out of control have blurred vision. It'll be one of their complaints. Same thing happens in the brain. Swells. You do the scene size up, all the usual stuff. Sounds just like the stuff we talk about when we do our scenarios. And this is basically the same approach we use, nothing new here. This is normal stuff. But what I want you to think about when you're looking at this is the documentation. Because this has to be in the record. We can't do good QA review on 3 sentences. Okay? You have to write a very well, I want to say like all-inclusive evaluation. You have to make sure all the important stuff is in there. Okay? So yeah, descriptive, narrative, whatever you want to call it, until we have a mechanism of doing this by just touching something on a computer screen that gives you all the information. But for the most part, you're going to have to write it. And it should include, in general, these types of questions and this type of documentation. You know, a lot of times when I give you the scenario, I talk about the living conditions. I tell you what the house looks like. This other stuff I'll tell you. Sometimes I'll tell you the patient's in bed, or they're in a recliner, or they're on the floor. Okay? So those are all important things that you need to put in your narrative, in your documentation. And it's not just because we need it for liability issues, but also because, you know, we need the information to know what's best to do for that patient. We talk about listening to the sounds the patient's making, to what you hear in the house, to their breathing rate. You know, I talk about touching them, smelling what the place smells like or what the patient smells like. You can tell a septic patient from a urinary tract infection by the stink. They smell like musty cats. You need to assess the airways. We talk about that. And this is just basic stuff. Did I give you that scenario with the patient that ate a mango and was running through the house gagging, choking on it?
Nope.
I didn't give you that one? That was the last one I gave.
Not us.
No, well, I guess you guys just don't deserve it. That was the last one I gave. They don't get those passed out to all of them on the web? No?
Oh, no, we do it, yes.
They just don't elect to go and look for it?
No, it wasn't included.
Wasn't included?
No,
Okay.
it wasn't there. Easy, buddy.
I know you, Jesse. I've known you too long.
No.
No, it doesn't. Okay, let's just look at this a second because this is something that you do see, but a lot of times we don't acknowledge it. These types of breathing patterns. Probably the most common ones you're going to see are going to be Kussmaul's, Cheney-Stokes, hyperpnea, apnea. You won't see apneustic a lot because it's really pretty specific for a brain injury. So when you see a patient with a brain injury who's unconscious, whether it's a stroke, a bleed, trauma, look for that kind of breathing pattern. That's what it's called. Because it is really pretty specific just to brain injury. You'll see diabetic ketoacidosis and general metabolic acidosis. You've all seen Kussmaul's. Okay.
We had a patient the other day that presented with every stroke sign in the world, but her breathing pattern was a bit different than I've seen. I mean, she was doing the pursed lip breathing, as in like she was like off gassing.
Was she
It was
consistent, or was she up and down with
It
it?
was a 15-minute. It was like within a 15-minute period. They called like right away. She was talking, eating, then couldn't walk. They laid her down and went straight to.
So there was no change in the rhythm of her breathing. It was the same.
She was laying there, and it was just. And it was, I've personally never seen it like that.
Was she alert at all, or was she obtunded?
Incomprehensible speaking, just couldn't control her arm. It was, and it looked like a complete obvious stroke. But I mean, like I said, the breathing was just a different pattern than I'm used to seeing.
Well, maybe it was a.
She was at the ER that day for they thought it was a detached cataract that went in her eye because one of her pupils, isn't that right? She was in the ER for one of her pupils being larger than the other. Her grandkids took her down, and then they said that they think it was just a detached.
Did they scan her brain?
We didn't.
You don't know?
And the grandkids weren't sure. They kept calling her Nana, but obviously there was something going on prior to it happening.
Yeah. Well, see, she would have a bleed, and the brain, it's going to depend on the pressure, because if she has a bleed and it's like a subdural or epidural, and it starts to herniate her, she'll blow a pupil.
Well, did you? Because I didn't assess her pupils. Did you assess pupils? Was one larger than the other?
They were fine. She had some kind of respiratory history before the stroke?
No. She did have a cardiac history. She was diabetic. Sugar was good. I mean, they literally saw her go from sitting and eating to inability to walk and talk, and they laid her down, and that's how we found her.
Yeah, it sounds like she probably had a hemorrhage,
Sound like, yeah.
because that'll blow your pupil.
Yeah.
Now, let me mention this because this is true. With cataract surgery, you do become what's called aphakic, meaning that one of your pupils, and these are an older procedure, I don't think they do this anymore, but one of your pupils would be unequal or big, or it would be big. So yes, that can happen with cataracts, but that would be something that should be known. I mean, I wouldn't think that I would make a diagnosis of that on a patient that came in and had a blown pupil and said, oh, it's just a cataract, and sent him out. So maybe she was there for a headache before. I mean, who knows?
They just said that the grandkids basically saw her eyes, and one of her pupils was larger than the other, and they took her down. They just said that it was a detached cataract, they said. And that's
Yeah.
what, that's what
Yeah.
the kids were telling us, so it could have been something else. The grandmother couldn't speak to us, obviously.
Yeah.
Anyway, it was just-
That wouldn't be the first thing I'd think of, but, oh well. Again, primary assessment of circulation. This just tells you having to deal with shock that we saw earlier. What you see in shock and increased intracranial pressure. So why do you get a lower pulse rate and a lower respiratory rate? What is that called? Widened pulse pressure, elevated blood pressure, lower respiratory rate with increasing intracranial pressure. What's that called? What reflex is that called? No, Beck's triads for the heart. Yep. Good job. So that is something you can see. Again, clinically, you're making a diagnosis that that patient has something going on in their brain. Okay? You didn't do a CAT scan. You made a decision based upon your vital signs, your history, and what you're finding on evaluation. It's a lost art. You're the only people who have the ability to do that anymore, because it's been lost by the medical profession. Let me back up a minute. You see where it says BIOT, and I can't read the rest of it? The irregular respirations, yeah. I've only seen that in very late findings in herniation. Usually we've intubated the patient by then, but I just wanted to mention that because we talk about some clinical evidence of increased pressure by finding some of these things going on. Now, let me go down. You all know decorticate, decerebrate, Cushing reflex is what that thing was that we saw in that little graph. Biot's respirations you saw in that other graph. Apneustic was there, so Cheney Stokes. Anisocoria, what does that mean? Okay, it means an irregular sized pupil. They're unequal and they're irregular. Okay? It could be a lot of causes. Be careful about telling a doctor that this patient's pupils are unequal, because I've had patients come in and the EMS says, well, their pupils are unequal. He's got something. And I look at him and I said, no, they're not. Almost everybody will have a little bit of difference between their two pupils. When they say anisocoria, one is big and one is small. There's no question about it. You can see it from across the room. Okay? So when you see that unequal pupil sign and you're saying, ooh, they have anisocoria, one is big and one is small. There's no question. They're not very, you're not standing there with a light like really trying to see it and oh man, see, it's just a tiny bit. No, that doesn't mean anything. Doesn't mean anything. Okay? Basic stuff of what you're doing. This is the physiology of what happens with ICP. And why does this happen? What's it doing to the brainstem? It's pushing it down through your foramen magnum. And that's where the brainstem controls all these parts. Now, at some point, you're going to be making this decision. But you'll be doing the transport. And as such, I would expect that those reassessments will occur. How far are you from North Collier, your closest hospital? So that means in that time frame, you guys should be able to do at least one more assessment, if not more. So I would not expect anybody to only have one assessment before they get to the hospital. Again, this is your usual stuff. When we do the certifications, this is stuff that you guys put up there. And we talk about Jesse. So what do you see on this patient? Yeah, it looks like, with this patient, it looks like his right side is paretic. Okay, his pupil, his eyelids don't look like they move. Okay, usually they tear on that side if they can't blink. Their face is drooping. What do you think this is? Let's say this, in this patient, that's the only findings you see. Okay. And everything else is normal. He doesn't have dysarthria other than what's limited by that. He's awake, alert. Yeah, Bell's palsy. Do you call that a stroke alert? Unfortunately, yeah, you would have to do that. You'd have to do it. In this particular guy, yes. And that's fine. Remember, you don't have a CAT scan in your pocket to scan their brain. And all the stroke alert does, well, all it does is it mobilizes that patient when he gets there to be able to go into CAT scan and bypass all the people waiting. That's all it does. Yeah. Because, you know, right now, time is important. What was I doing? Oh, okay. All right, well, I'm going to leave it there. This is all the stuff you already do. Well, it depends, because it can be caused by herpes, by the chickenpox virus. There's really nothing that's great. It depends whether or not they have pain with it. You can use steroids. You can use anti-chickenpox drugs like Valtrex. You can use Lyrica, you know, gabapentin, those types of drugs if they're having any pain with it, and sometimes they do. But really, the most important thing is to give them an ointment to put in their eye so it doesn't dry out, because they'll tear the cornea every time it's exposed to the air like that. It dries out and it'll tear just moving their eye around. The other part of Bell's palsy is tic douloureux, which is painful. Severe pain in their facial nerve, their fifth cranial nerve, and that's brutal for these people. It really hurts. All right, well, I'm done with this. Okay, guys, all we did was just to stimulate a discussion about these issues. Greg, did they send out the new protocols for that? For stroke?